All right, good morning. My name is Haley Bell. I'm the training program manager for Telehealth Rocks, and I have the pleasure of hosting today's session. Telehealth Rocks is a federally funded program designed to support behavioral health in schools. We do this by addressing social determinants, supporting school-based services, and offering trainings. And Lenny, if you could progress us to the next slide, please. So just a few notes before we get started. Today's session is being recorded, so we will send that to you all afterwards in that follow-up email. And if you have any questions throughout the session, please feel free to use the chat and ask those. We'll have some time at the end to cover those. And then if you could please just make sure that your either last name and first name are visible on Zoom, or if you can put that in the chat, that's really helpful for us to track attendance later on. Next slide, please. And we have no disclosures for today's presentation, and everything that is being presented today is evidence-based. After the session, like I said, we'll have that follow-up email. That'll include all of the links and resources, if any come up today, along with slides in the recording. Just give us a little bit of time to get that processed, and we will have that out to you all. And then the certificates of attendance, those will be emailed after the series ends, so after that final session in December. And in the meantime, feel free to send any additional questions you have to our Telehealth Rocks inbox. It's listed there on the slide, and we'll have that in the chat for you as well. And we're excited to have Leni Swails back with us today. Leni is a clinical child psychologist at KU, and she'll be leading today's session as well as the one in December. So I will go ahead and hand it over to you, Leni.
Well, it's good to see everyone today. I'm excited for our topic. Thanks to everyone who attended our last session in October and voted about the things that you're interested in learning more about. One of the top contenders was talking more about autism. So that's a topic that's near and dear to my heart. So I'm looking forward to reviewing that with y'all today. Um, in addition to being a clinical child psychologist at KU Medical Center, I'm also our clinical site director for our autism program. And so one of the things I really enjoy and am passionate about is we do a fair amount of autism diagnosis and evaluation, and then also treatment. So today, we're going to be reviewing together the diagnostic criteria for autism to understand more about that. We'll also be talking about some common associative features that go along with the diagnosis of autism. And then finally, we'll be reviewing some treatment strategies that might be helpful to use in the school setting. And then we'll be wrapping up with a relevant case from one of our attendees, talking through some young children with suspected autism. All right. So, when we think about a diagnosis of autism, um, it can really vary between different people. And there's an old saying that if you've met one person with autism, you've met one person with autism. And the idea behind that is there can be so much variability from person to person that if you know just kind of one presentation of it, it might look really different when you meet another person with autism. However, despite that variability between individuals, there is a set of clear symptoms that are part of the formal definition of what is autism. And this is what we use when we're doing evaluation and diagnosis. In order to have a diagnosis of autism, we look at two key areas. And the first is differences in social communication skills. A lot of times we think about this as really being the core of autism. And the reason for that is in order to have a diagnosis of autism, you have to have three specific symptoms of social and communication differences. And that's represented by each of the three blue bubbles here. So you have to have differences in social reciprocity, nonverbal communication, and relationships and shared play. Now, where you get that variability from person to person is what examples of differences in social reciprocity, the examples could differ from person to person. So, for example, differences in social reciprocity, what that means is having difficulties with a sense of back and forth in social interaction and social connection. And so for some kids, that might involve not initiating interactions, meaning that they're really independent and not seeking out attention or engagement from another person. So for a young kid, this might be someone who's playing with the toys independently, but not showing or sharing toys with other people or trying to initiate play. For someone who's older, this might be someone who really enjoys kind of being at home with their own preferred activities and isn't really seeking out that connection with others. Um, This also might involve someone who has the ability to communicate verbally, but because they're not as interested in that social connection, they have a really low frequency of communication. So, for example, I saw a child yesterday who was 4 years old and had about 5 words in their vocabulary. But I spent about 3 hours with him and he never said a single word. And his parents said that's pretty common, that he has a very low frequency of communication. Um, in addition to like, on one end of it could be that low frequency of communication. On the other end, it could also be someone who is a verbal communicator, but struggles with having a fluid back and forth in conversation. So yesterday afternoon, I saw a 13-year-old who was we diagnosed with autism. And for that individual, when you got him on a topic he was interested in, he would just go for it and would talk for a really long time. For him, that topic was classic cartoon characters. And he wouldn't really pause to wait to see if I was listening. He didn't really respond when I made a comment about my own thoughts about that. He didn't respond to what I had said at all. He was just kind of dominating the conversation. And again, it didn't have that reciprocity, that sense of back and forth and interaction. So does that make sense? You can kind of see deficits of social reciprocity that range from someone who might be a verbal communicator but struggles with back and forth in conversation, all the way to another kind of extreme would be someone who isn't seeking attention with others, not talking with others, is very independent. So the next blue bubble was differences in nonverbal communication. So a lot of times people will think about reduced eye contact, which is one possible example of differences in nonverbal communication. But other things we also look at is decreased gesture use. So someone who isn't using gestures like pointing, nodding their head, shaking their head, or using more complex gestures like describing what things look like with their hands, like it was this big or is this tall or it went zip like that. This gesture one is one that we think about a lot for kids who have young children who have language delays, because for a child who has language delays but not autism, sometimes they'll even try to compensate for the fact that others can't understand them by using more gestures to try to communicate with other people. But on the other hand, for a child with autism, you don't use, because you also see those deficits in nonverbal communication, you wouldn't necessarily see them using a lot of eye contact or gestures to make up for those communication delays. Other things we look at is facial expression use. So some folks will have really flat affect, and then also the ability to read and respond to other people's nonverbal cues. So you have to have differences in social reciprocity, nonverbal communication. And then the last one is ability to understand or maintain relationships or engage in shared imaginative play. So this might involve someone who has difficulty developing friendships or might have difficulty with engaging in play or being interested in peers. You can also see, say, for example, with a teenager I saw yesterday, that person was really interested in friendships, really wanted to have friends, but struggled with understanding social rules or norms. And often he was really blunt, wouldn't have a filter, and then those would lead to situations where he would damage relationships that he really, really desired. Um, uh, you can also, one of the things I think a lot of folks know is that you might see differences in imaginative play. That's actually categorized as a social skill. So that's where this kind of gets categorized for the symptom list is difficulties with developing pretend play or engaging in that with another person. So in order to have autism, you have to have all three of those social communication differences. But the specific examples can vary from person to person. The second part of autism is some really specific types of behavioral differences. And for this, there are four symptoms listed in the DSM, in the Diagnostic Statistical Manual that we use for kind of defining what autism is. And those four symptoms are the blue bubbles here. You only have to have two of these in order to have a diagnosis of autism. So you can kind of mix and match between them and still have a diagnosis of autism. So the first is repetitive movements, language, and play. So repetitive movements might include things like hand flapping, toe walking, repetitive spinning in circles, pacing, finger mannerisms. Repetitive language could include echolalia, so repeating what someone says immediately after they say it. It can also include scripting or repeating things they've heard from videos or teachers or other people in situations where it doesn't make sense. Um, you can also see formal language, so speaking in using language that seems unusually formal or advanced for the situation, or not using contractions, and then it just sounds sort of professorial. And then the last one is repetitive play. So this would be things like lining up or categorizing toys, repeating the same actions over and over and over in play, or focusing on a kind of unusual parts of toys or objects. So the kiddo I saw yesterday morning who had that limited language, he really enjoyed repetitively ripping paper, was one of his favorite things to do, instead of playing with toys in a way you might expect. The next blue bubble is insistence on sameness. And this is when someone really likes to have things as expected. And so it might be really hard when there's been a change in routine. They can also have some kind of concrete thinking where they are really have rigid thinking patterns or can be very black or white in their understanding of things and have difficulty with understanding ambiguity or exceptions to rules. And then you could also see some rituals. So, for example, insisting on eating the exact same food every day, or having a very elaborate, more than a usual elaborate bedtime ritual. So, kind of needing things to be kind of just so. Restricted interests is a really fun part of autism. And that's when someone has a really deep passion or sometimes obsession with a certain topic or character. And it can either be something that's really an age appropriate thing to be interested in, but that interest has gotten unusually intense. So for example, you'll see kid like a preschooler who's interested in Paw Patrol or number blocks. Like those are typical things to be interested in. But when it gets to the point that they have to carry those Paw Patrol characters with them everywhere, they won't play with anything besides those Paw Patrol characters. If they're in Walmart, they have a tantrum because they have to go see the Paw Patrol characters. That would be when the typical interest has become unusual in its intensity. You can also see intense interest in unusual topics. So I've had kids who are interested in toilets, kids who are really interested in water was the young kid I saw yesterday morning. I had a water bottle in the room where we were working together. He grabbed it, even though it wasn't his, dumped it in a bin, and immediately started kind of engaging and playing with the water. And his parents said anytime he sees water, he's right there for it. And that would be sort of an unusual interest. And then finally, you can see sensory differences. So sensory differences, I like to think about it being related to three different categories where you can see sensory seeking. So that might be someone who is eating things that are non-food items or licking or mouthing toys. You could also see sensory seeking with looking very closely at things or visually inspecting things from unusual angles. You can also see sensory avoiding, which is when someone's very sensitive to loud noises, might have certain food textures that are really uncomfortable for them, or have clothing sensitivities. And then finally, you can see sensory underreactivity. You see this most often related to pain. So you can see some folks with autism will have an unusually high pain tolerance, and they don't react as expected when they're hurt. So one of the kiddos I saw yesterday, the parents told a story that he had fallen on some glass and had a really big gash and cut, and was still kind of running around playing, and they didn't notice until they saw kind of the blood dripping. And so that would be an unusually high pain tolerance. So again, to refresh it, in order to have a diagnosis of autism, you have to have all three of these social deficits in the blue bubbles, and then two of these four possible repetitive behaviors. Okay. A little bit more about sensory differences. What's really interesting is sensory differences weren't actually part of the formal definition for autism until 12 years ago in 2013. Before that, it was just considered like an associated feature. However, they were seeing more and more with the research how much individuals with autism could be impacted by sensory differences. And so they kind of added that as part of the diagnostic criteria. Sensory differences are not unique to autism only. And you can actually see that everyone everyone has their own sensory preferences, right? So like for me, I tend to be someone who's very reactive to certain smells. So that's kind of one of my sensory preferences. You can also see that that younger children tend to have more strong sensory reactions. So like young kids are more often just in general going to have sound sensitivities, or more often are going to have other types of like sensory preferences. Like toddlers, mouthing is kind of part of a typical part of their development, right? What's interesting is you can see more severe sensory differences in individuals who have diagnoses like autism, ADHD, or anxiety. And then the other thing you can also see is that whereas the general population might have some sensory differences when they're really young, um, over time, those sensory preferences decrease, except for some of these other groups where they continue to have kind of that higher level sensory difference related to autism, anxiety, or ADHD. And then finally, if you look at the research for autism, the sensory differences in autism tend to be more extreme than they are for some of these other diagnoses where you can also see sensory differences. So I see a question in the chat. Is it possible to replace a sensory need with something similar, safer, or hygienic? How would this work with a child on the spectrum? Yeah, I think you're onto a great idea, which is how do we meet that same underlying functional need? Remember last time we talked together about functions of behavior, and one of the ones we talked about was sensory. So if someone is having this sensory need or getting this kind of sensory feedback from, for example, mouthing or eating non-food items, then we try to figure out another way they can get that same need met that's safer. And so a common replacement for mouthing is having a child wear a jewelry necklace, sort of a silicone necklace that is safe for them to chew and bite on. And then you would redirect them when you notice them trying to eat crayons. You would then redirect them to the sensory necklace that they could chew on more safely. Um, so the other thing is that autism, we can reliably start diagnosing autism as a toddler. And then here we do evaluations from 12 months to 18 years. And we only cut off at 18 because we're the pediatrics department. But what's really interesting is they've done some research and found that symptoms of autism can be detected really early in development. So they have done these cool studies where they took individuals they knew were at high risk of developing autism because they had a sibling who had autism. And they tracked them starting in infancy over time. And we're looking at eye gaze. So they were looking at basically eye contact. They had kind of little electrodes set up so they could tell where the baby's eyes were looking. And they found that um, eye contact started to be noticeably different in individuals who were later diagnosed with autism as early as 2 to 6 months. So I think that's really interesting to see that you can see some of these early indicators with autism really, really early in development. Some other early markers of autism is, again, the same kind of thing where they're looking at high risk individuals and then tracking their development over time, and then later being able to look back and say, oh, these were the kids who were later diagnosed with autism. One of the other things that is also really different between those groups is response to name. So individuals who are later diagnosed with autism, responding to their name when called is another important early indicator. And then also looking at people, so that eye contact that we were talking about before. So some associative features of autism. Now, these are not things that are part of the formal definition of autism, but these are co-occurring difficulties that are more common in autism. So ADHD, depending on the study you look at, there's about a 40% co-occurrence rate with autism, where someone already has a diagnosis of autism. Um, I know that here we routinely do screening for every kid to see if they also have ADHD because there's that 40% co-occurrence rate. Meltdowns and tantrums is really common across all childhood behavioral and mental health conditions. Um, and so sometimes we'll get referrals for autism, and when we ask why, like why are we concerned for autism, the only answer we get is, oh, because they have really significant tantrums and out of control behavior. But remember, that's not part of the formal definition of autism, right? That's not part of the symptoms. So it could be a variety of things that's causing that. However, about half of children and adolescents with autism also have some aggressive behaviors. And kids who have both autism and aggression are more likely to also have sleep problems, which makes sense. I'm a lot crankier if I have sleep problems, and that applies to folks with autism too. They're also more likely to have self-injurious behavior, significant sensory differences, and then also younger kids with autism are more likely to have that aggression, and it tends to decrease over time as they get older, which is the case for aggression in other behavioral diagnoses too. Other common co-occurring things is anxiety. Um, so depending on the study you look at, for kids, about 20 to 30% of kids with autism will also have an anxiety diagnosis. And then depression is another thing we look at, especially when we're getting into teenagers and young adults. Um, Seizures is another thing that's more common in this population. So about 10% of individuals with autism also have epilepsy. And it tends to be even a little bit more likely if the person with autism has intellectual disability, then that creeps the prevalence rate up even a little bit higher for epilepsy, or if they have an underlying genetic syndrome. And then things like picky eating, constipation, or sleep problems are more common in autism too. So now that we've had a chance to review the diagnostic criteria, some of the co-occurring features you can see in autism, now I'm going to shift gears and talk about some intervention strategies. In general, I think a lot of the intervention strategies are focused on how do I make what's happening more predictable and understandable to the individual with autism. So one way that we can make things more predictable and understandable is with our communication. So I'm sure we've got some speech paths in the room and you're like, yes, communication, that's the key here. And I am totally with you. So when working with an individual, we want to make sure we're using really clear and non-literal and really clear language so that our point is really clearly getting across, and try to avoid, unless we're explicitly practicing using figurative or non-literal language, we want to try to avoid that. So if you're really trying to get an individual to follow a direction, you want to use really clear, specific commands like please sit in the chair, as opposed to something like, oh, don't you want to sit in the chair? Or why don't you sit in the chair? Phrasing things more indirectly like that could be ambiguous. And that can be harder for someone to understand, oh, I actually need to do that. And that's not just the case for kids with autism. I think that applies to all kids and all individuals too. There's been so much more research over the last couple of years about forms of alternative communication and how helpful that can be to families. So we're pretty often talking about getting an evaluation for an AAC device, which is a speech generating tablet that can help an individual be able to communicate more effectively. I think a lot of times parents are really worried that using a communication device will slow down the individual's ability to develop language. And the research shows that's not true. It doesn't hinder the ability to develop verbal communication. What it does do is it can help reduce the individual's frustration, which can reduce those aggressions and tantrums and acting out behavior because they can get their needs met more effectively. And it also helps reduce the frustration for parents and teachers because you know what that kid needs, and that can be really helpful. And then it also helps to teach the individual that the way to get your needs met is by communicating with another person. For example, if you have a tablet and it has cookies on there, the child pushes the button and then the tablet says cookies and then they get their cookie. And they start to see over time, oh, it's when my teacher or my parent hears cookies that I get that. So I need to communicate with them. And then over time, the hope is that they'll start to verbally say it themselves and sort of cut out the middleman of the iPad or the tablet.
Lenny, we have another question in the chat that came up.
Okay. Have you seen or does anyone have ideas to replace a sensory or stimming behavior that consists on vibrating the tongue with a finger? Um, I haven't heard that one very much. That sounds like a really unique sensory need for that kiddo. I have heard of things like for some kids who don't like to brush their teeth, having stronger sensory input has actually worked better for some kids. So using like an electric toothbrush that vibrates. So I wonder for this kid if something like that would be helpful. Um, no, that sounds really unique. I see a comment from Lydia too that they had some success with their kiddo with AAC and actually helped push their language development forward. That's really cool. Um, some more strategies that can be helpful is again, we're trying to make the world more predictable, right? So having consistent routines, um, using things like visual calendars or visual schedules, giving warnings for changes or transitions. So that might involve sending a note home and letting the family know, hey, we're going to do a school party tomorrow. So kind of giving the family advanced warning. And then also uh, um, things like visual timers can be super helpful. We used to, back in the day, we used to use a lot of these time timers, which you can buy, and then you can kind of set like, oh, we have 5 minutes left remaining, and then you turn the little dial, and then it would be shaded red. I often find that just like the cell phone clocks are pretty much the same thing now because they kind of count down visually. So using timers can be really great. I see a question about would an AAC device be appropriate for a 14-year-old with autism? I think potentially yes. It depends on the individual. I would always say they need to have an evaluation with a speech pathologist to figure out if AAC is appropriate. And then also there's a whole bunch of different types of AAC programs. And so they really need to work with a speech path to figure out what's the right AAC for them. But yeah, there's lots of, I've met lots of teenagers and young adults who use AAC. And yeah, Davina, I totally agree. OTs are great places to go for specific sensory recommendations or interventions. Um, Again, try to focus on increasing predictability, visual schedules where we're showing pictures of what to expect or what's going to happen next. And you can use these types of visual schedules either for the schedule for the day. And so that's what you kind of see in the bottom left where it says first, second, third, and fourth, and then you would kind of plug in the pictures there. And then you could also use them for learning a new task or routine. So on the right-hand side, it's washing your body in the shower. And it has all the steps of turning on the water, adjusting the temperature, wetting your body. And so you can also use a visual schedule for learning a set, like a new developmental skill or a new adaptive skill. Social stories is a great strategy for teaching a child a new skill. And that's where you kind of make a personalized story to that child, and then let them know what behavior you want to see and why it's important. So, for example, I've made a lot of social stories around safety with pets, and so we'll talk about, Joyce, lives at home and she has two cats. Her cats' names are Simon and Timothy. She likes to play with the cats. Um, it's important that we play with the cats. We use gentle hands and gentle bodies. Joyce can show gentle hands and gentle body by petting with two fingers, standing back if they hiss, and kind of laying out in a really concrete way what they can do. And then also it might even lay out things that we're going to avoid doing. So when Joyce pulls the cat's tail or picks up the cat, that's not using gentle hands and gentle body. Um, when I make social stories, I'll often, if it's developmentally appropriate, I'll involve the child in that. So we'll pull up Google Images together and find pictures that kind of fit with the page that we're making, and then we'll make that social story together, and that can help kids be really bought in and also help really learn those the concept you're trying to teach them. Once you finish making the social story, the magic is in the repetition. So it's not just making it, now we're done. And then what we're going to do is every day until we're really good at that particular skill, we're going to read that story together. And that way they can kind of hear repeatedly what the expectations are. Video modeling is another strategy that can be great for learning a new strategy. And what this looks like is, and I feel like this works great in our current like kind of video, like cell phone driven age. For video modeling, what you do is you take a video of a child doing the expected skill. So maybe it's saying hi and greeting peers. And you would kind of pull up your cell phone camera with parent permission and etc. And have the child walk into a room and they would say hi. And so you kind of are recording them doing what the expected behavior is. And then you look at it afterwards, and if there was any errors, if the child did something you didn't want them to do as part of it, or they were fumbling, you would edit those out or to do another retake. And then once you have kind of like, yes, this is what we're trying to get them to do, this is the positive example, then you would have them watch that sort of like that social story repeatedly. I've done this a lot with kids, and we often call it being a YouTuber. And kids love it. They love being their own YouTuber and the star of this. And then I've used this for learning social skills like Greetings. I've used this for social skills like inviting a kid to play. I've used this for learning a new strategy, like learning how to swallow pills. You can do this for things like learning how to wash your hands. So you can use it for either for learning a new social skill or a new adaptive or developmental skill. Um, ABA, I'm sure a lot of you guys are familiar with this, is a type of therapy that's has a lot of decades and decades of research support behind it for individuals with autism. And it's based on that idea of behavioral learning principles and a lot of that repetition or rewards. So what they'll do is they'll break those tasks, like learning to bathe yourself, down into really small steps, like turning on the water, wetting your body, soaping your hair, soaping your body, and then they're going to teach potentially one step at a time, and we'll kind of put it all together at the end. And then we'll also work on accepting approximations. So for example, if someone's like just starting to learn how to wash their hair, maybe they won't really get all the sections right, but they got a little bit, and we're going to accept that at first as like, yeah, you did it, you washed your hair. And the next time we're going to kind of up the ante and expect them to do a little bit more of it. And when ABA is most effective is when we're using really frequent and meaningful rewards. So we want to make sure that ABA should, in a lot of ways, look like fun, look like play, where we're incorporating whatever the child's interests are into learning those new strategies. So it should be really fun. I'm going to pause just for a quick second. I'm sorry, guys, I've got a cold. Okay, sorry, I need to be able to breathe. Okay, so some more strategies that can be helpful is incorporating special interests into the interventions. So, for example, if I'm working on coping skills with a kid, and that kid also has an intense interest in Darth Vader, instead of talking about deep breathing, we're going to talk about Darth Vader breathing, which sounds like right? Kind of like Darth Vader. Or I've also had some kids who are really interested in Jigglypuff and Pokemon, and we've done Jigglypuff breathing. So the same kind of idea. We'll also want to involve students and try to help us tell us like what your interests are, tell us what you're passionate about. And then I love the creativity this requires to kind of build that into your therapeutic interventions. This is another example of a way that we'll use preferred topics when working on coping skills. So this is called a 5-point rating scale. So we're trying to help the child rate the intensity of their angry feelings on a scale of 1 when they're feeling good, all the way up to 5, which was very mad. And so some folks with autism have a really hard time identifying their emotions or the intensity of the emotions. So one of the interventions we'll use is developing a 5-point scale to try to help them start to recognize, oh, this is how big my feeling is. For this child, her intense interest was guinea pigs, which was adorable and really fun. So I had her help me go online, and we found pictures of guinea pigs that she thought showed number 1 feeling good all the way up to a 5 very mad with that angry demon looking guinea pig eyes. In addition to that, we tried to work together to say, okay, what do you look like, or what do you do when you're at a 5, when you're in the middle at a 3, and when you're feeling good at a 1? And so we wrote down some of those behaviors. So when she's a 5, she might have an angry face. She might be hissing, hitting, and punching. When she's in the middle, feeling not so good, she might have a flat face and no smile. It might be grunting. It might be whining. But when she's feeling happy, she's smiling and using kind words. So we try to then add some behavioral anchors that the child helps you identify to each of those different numbers. And then the last thing we did when we were working on making this together is identify what helps her get from a 5 down to a 4, down to a 3, down to a 2, down to a 1. And so we listed a whole bunch of different things, not necessarily in order, but a variety of things that she identified help her calm and self-regulate, like playing with her guinea pigs, hugs, talking to a grown-up, taking deep breaths, taking a break, or going swinging. So this is an example of it's kind of merging a lot of different autism specific strategies. We're incorporating special interests. We're working on helping her identify emotions and communicate. We're making it really visual and concrete for her. So that's kind of how this was helpful for this kid. And then the last thing I'm going to talk on really briefly is that the other interventions we'll want to think about for autism is how do we make social interactions more concrete and predictable? And so social interventions is a huge part of autism. One of my favorites is peer-based instruction intervention or peer-mediated interventions. And this is when you pair the child with autism with a child who doesn't have autism, a neurotypical child. And then often we'll even pick a child who's doing pretty well socially, might be popular. We'll have the adults, the interventionists will um, be kind of thinking for themselves, okay, what's the specific social skill I want to teach today? For example, like asking another kid to play or taking turns in play. We'll have the adults will also set up the environment, so put out some toys that are appropriate for practicing that skill. They might even pre-teach the peer, like, hey, this is what we're working on today. And then they'll have a reinforcement system of, okay, if we're working on inviting someone else to play, each time we hear someone do that in a right way, I'm going to give you a thumbs up or a sticker or whatever. And we'll do that reinforcement system both with the child who has autism as well as with the neurotypical peer. And there's lots of evidence that this type of peer-mediated intervention can work really well across a huge range of ages, all the way from preschoolers through high school and young adults. And the research has shown that you can see positive growth in communication skills, social skills, joint attention and play, and then also in academic and mental health skills. Okay. Well, I see that there were already a couple of questions in the chat. Um, So I see a comment from Davinia about they love Oasis training. So Oasis is a parent training program teaching parents the behavioral strategies that you would use in ABA. And it's provided through some of my colleagues here at KU through KCART. We can send out the link for that. And it's offered to parents through telehealth. So it doesn't matter where you are in the state, there's opportunities to access that for a family. There's also some Oasis training programs that are specific to professionals as well, not just targeted on parents. So it could be a good thing to look into if you're interested in learning more specific intervention strategies for autism. And then Corey has a question about, can you talk on atypical presentations of autism such as PDA and RSD related to behavior? Um, Corey, I'm happy to talk about PDA. I'm not sure what you mean by RSD, so if you mind to spell out that acronym for me. Um, PDA stands for pathological demand avoidance, and it is a concept that's come primarily out of the UK. And it's the idea that some individuals with autism will also have this kind of subtype where they really struggle with um, following adult-driven directions. And it could might have a lot of resistance, potentially from a place of like anxiety around following directions. Um, right now, there is not a lot of good research supporting pathological demand avoidance, and it's actually not there's no it's not accepted in the DSM, which is the kind of defining manual that we have for mental health and behavioral conditions. It's one that I think that they're trying to do more research to see if there's some validity to that or not. But right now, PDA is not one that is a diagnosis that we make because it's not currently accepted by the DSM. Now you can see difficulties with following directions with individuals who have autism. Sometimes that's because they're not understanding the direction, so it can be part of communication differences. And it could also be part of like not wanting some of that rigidity of like not wanting to follow someone else's instructions and wanting to do kind of what someone is already their existing routine or do what they're already interested in. Um, and I would say that we want to use the same strategies we use for anyone who has autism in those situations. Another diagnosis that is in the DSM is called oppositional defiant disorder or ODD. And that's for someone, and they don't have to have autism, but that's for any any individual who has kind of this persistent difficulty following adult-driven directions, might be persistently irritable or argumentative. And some of those characteristics also match onto some similarities with PDA. And I think those strategies we'll talk about in our next session that's focused on ADHD and acting out behaviors. Yeah. Um, RSD, that is a new one for me, Corey. So I don't feel like I have an educated response to you, but I'm gonna look into it and see if I can get some resources and I'll send them out to the group